Microvascular decompression surgery is a small procedure performed behind the ear where about a nickel or a quarter-sized piece of bone is removed, and then under an operative microscope, the surgeon, myself, goes in and finds a blood vessel, usually, or two, pressing on a nerve that's making the nerve irritated and creating space between the offending vessels and the nerve by placing Teflon sponges or pillowcases in between the arteries and the nerve. That's the whole procedure. My name is Anthony D'Ambrosio. I'm one of the brain surgeons at the Neurosurgeons of New Jersey, and I focus my practice on microvascular decompression surgery. The more that someone performs a procedure like an MVD well, the better their patients do. The faster the recovery times, the better the outcomes, the faster and safer the procedure itself is. So for all those reasons, I felt that as opposed to being a generalist, being hyper-focused on perfecting the MVD it's valuable to patients, and that's why I do it. In essence, it is truly a surgically curable disease process, which means the procedure itself is explicitly designed to target the exact area that's causing your problems. It doesn't give you a bunch of medicines that might go everywhere else. It doesn't just treat the symptoms. Microvascular decompression is a laser-focused approach to go in and structurally correct the anatomy that's causing the problem safely. Skull-based training allows a surgeon like me to navigate around and protect all the vital structures that we have to protect, like your hearing, your brainstem, all of the blood supply to your brainstem and your brain. All of those structures are around. The environment that we have to navigate safely is in the area, but during the surgery, microvascular decompression surgery is designed to protect all of those structures. So the protective mechanisms that we use include correct patient positioning, correct anesthesia, neurophysiologic monitoring, meaning we listen to your hearing, we make sure your hearing works. We monitor your facial nerve, we make sure your facial nerve works. We monitor your brainstem function from the convexity to your feet throughout the procedure. So all of those things are protected. The microvascular decompression surgery is just designed to alleviate the external insult that's going on by the artery without hurting anything. It actually is protective. I do screen my patients before I offer them microvascular decompression surgery for a lot of reasons. Sometimes the diagnosis is incorrect, so that needs to be screened out meticulously because you never want to operate on someone that the diagnosis is in question. People have to have good, non-invasive MRI imaging so I can see what one might encounter at the time of surgery, and if there isn't a qualified vessel to move, you shouldn't ever be offered microvascular decompression surgery. So ultimately it's my responsibility to make sure that my screening processes are appropriately discussed and implemented. People understand why they're being selected for or against microvascular decompression surgery because it's for their own safety, it's for their own good. Once someone is properly selected for surgery, it's always up to them as to whether or not they want to go through with it, but at least they know it's an option. Pre-screening someone's imaging is critical. It also is, respectful to the patient, right? So if someone's had really good imaging and it shows that there just isn't a vessel there, we want to let them know that maybe the report was wrong or maybe their understanding of the report was wrong. You never want to have surgery if it's not going to be successful or there isn't a really, really good chance, more than 80-90% chance that you are going to see benefit. So I like to let people know what their imaging shows in case they're getting second and third opinions. I want them to go out into the world equipped with my interpretation of the images that I reviewed myself. I think it's important. The process of performing MVD surgery started years ago, right? It's training, it's building your team, it's communicating with everybody in the room so that the whole environment is very relaxed. There's nobody in the room who doesn't know what to expect from me on the day of the operation. There's no production outside of focusing on what we're there to do in the room. The whole team knows that, I know that, and that's really philosophically and culturally the way that I set up my operative theater. excellence or mastery comes from a lot of things, right? There's training, and there's just all these other things that one could claim responsibility for outcomes. But to me, one of the things that you got to try to control what you can control. You're always ready for variables that you can't control, but you certainly should not expose any patient to variables that you can control. And that's what I try to do. I do that with every surgery that I perform, and I've found that consistency and that discipline to keep your variables to a minimum have resulted in excellent outcomes for my patients. Hand selecting your operative team, especially in brain surgery, is really important, right? It's a rare procedure to be performed. I feel very strongly that everybody in the room that's helping out is just as important as I am. A familiarity with your individual role on any team is huge. If you aren't familiar with what instruments to hand me or what sterile supplies to go get, that could lead to delays. That could lead to a handoff that's wrong. Any of those things just need to be eliminated, right? So by selecting a team that feels comfortable with the surgery, by communicating my goals of the surgery with them before the surgery and after the surgery, everybody's performing at a 10 out of 10. And all of that is directed to the patient's outcomes. So I take pride in doing everything in my operating room. From when the patient rolls into the room to when the patient leaves the room, I'm there. I take full responsibility for everything that's happening. I know where all my monitoring wires are. I understand if the patient's padded correctly when we lay them comfortably on their side like they're holding a pillow. I understand neck flexion and rotation. I see it all. It's not covered up. To me, that is essential to making sure while I'm under the microscope in a very small area, I understand what's going on around me because I saw it all. That's something that I think I would want for me. That's something I would want for my loved one undergoing, something that's important. So that's why I do it. I do it because I think it's the right thing to do, and I also know it results in the best outcomes. Human judgment and experience is still, and I think always will be, the only way to do this right. There isn't an algorithm. There isn't an agent. There isn't a website that can actually do what we can do in the operating room. You have to make sure that you know how to handle everything, even if the lights go out. There is no substitute. There is no artificial intelligence that can replace what we know.